Good morning, everybody. Today we will discuss a controversial molecule, reverse T3, and its space in clinical practice. I am Dr. Neeraj. In the wellness biohacking community, reverse T3 is often over-sensationalized as a sacred culprit for weight gain. Conversely, in the most rigid academic circles, it is dismissed as a useless byproduct. Now let's balance between these two and navigate a middle ground. Reverse T3 is not a toxin. It is an invaluable biochemical sentinel. It acts as a metabolic survival switch, signaling that the body has shifted from its priorities from growth and thermogenesis to conservation and survival. To understand this, let's look into the biochemistry, the path of iodine atom. To understand reverse T3, we must revisit this. Thyroxine or T4 is a prohormone, the fate of which depends entirely on the iodide atom which is removed from the T4 by the deiodinase enzymes. Outering deiodination by type 1 and type 2 deiodinases yields T3, which is the active hormone that binds to the nuclear receptor with high affinity. If it is inner ring deiodination performed by type 3 and to some extent by D1, deiodinase 1, RT3 is formed. RT3 is an isomer of T3, but it is biologically inactive at the nuclear level. In fact, it is a competitive inhibitor, although a weak one. The primary significance is not what it does, but what it represents. It represents a diversion of substrate from metabolic activity. So the core concept is that redirection of metabolism happens in healthy euthyroid individual. The body maintains a balance between T3 and reverse T3. However, during non-thyroid illness syndrome, also known as acuthyroid state, this balance undergoes a violent shift. When the body encounters severe stress, as in sepsis, myocardial infarction, starvation, or a major surgery, several things happen simultaneously. D1 and D2 activity decreases, so peripheral T4 to T3 conversion drops. D3 activity increases, so that the inner ring deiodination and shunting towards more of RT3 happens. Also, on the other hand, clearance of the enzyme decreases, and the breakdown of reverse T3 is inhibited and pent up. So this is a perfect silent storm of low active T3 and high inactive RT3. Now, what is the survival logic? Why would the body do this? So in a crisis, thermogenesis and high basal metabolic rates are expensive. By lowering T3 and raising reverse T3, the body effectively enters a hibernation mode, conserving energy for vital cellular repair and immune response, which are the need of the hour. Now, what is the clinical utility of this? The differential of suppressed axis, that is the clinical utility. This is where RT3 becomes a diagnostic powerhouse for a consultant. You will be often called to the ICU to see a patient with a low profile, that is low TSH with free low T4. The question is whether this is a acuthyroid state or a central hypothyroidism, which is a pituitary disaster. The RT3 fork in the road. If the pituitary is truly falling, that is central hypothyroidism, the total pool of T4 is low, so RT3 also should be low. With less of T4, RT3 also will be low. So if the patient is having a non-thyroid illness, the T4 might be low due to protein binding and shift, but the D3 enzyme is working overtime to convert whatever is available T4 to reverse T3. So in this way, you can differentiate in a sick ICU patient who has a low TSH and a low T4. By measuring the reverse T3, you can say that if the reverse T3 is normal or high, it is a sick thyroid state. Or conversely, if it is low, it can be a central cause. So this way, you can confidently tell the primary team who sent the consultation that there is no need to work up for a pituitary tumor and treat the underlying sepsis or crisis. Now coming to the last part of it, we will discuss whether this change in physiology is it an adaptation or a disease. The most heated debate is whether low T3 state is a pathology that requires correction. The argument for adaptation is that the majority of clinical evidence suggests that shift to RT3 is a protective adaptation. Many large-scale studies, including the Vandenberg clinical trial, have shown that treating ICU patients with T3 or T4 do not improve mortality and may in fact increase mortality slightly by increasing myocardial oxygen demand. The argument for disease is that some argue that if the illness has become chronic, the low T3 state contributes to muscle wasting, diaphragmatic weakness, and impaired cardiac output, essentially converting it into a metabolic trap that prevents the patient from weaning off a ventilator. Now, we should follow evidence. We are clinicians. We treat the patients, not the lab value. In this setting of acute illness, high reverse T3 is a symptom of the body's wisdom, not a failure of thyroid. So always try to interpret in terms of T3 RT3 ratio in a chronic setting, in an outpatient clinic. When you see patients with normal TSH but very high RT3 and low normal T3, this is often seen in chronic caloric restrictions. The body thinks it is starving and conserve significant emotional stress, and also in high cortisol states where glucocorticoids are known to inhibit D1 and stimulate D3. Another condition is chronic inflammation. Like cytokines like TNF alpha and IL-6 pour into this and drive the D3 and put on the survival switch. While these patients don't have thyroid disease in the classical sense, their RT3 are telling you a different physiology, that their physiology is in a distressed state and it is switching off. The solution is not thyroid hormone, it is addressing the why behind this. So to conclude, reverse T3 is a biochemical brake of the human body. When it is high, the body is saying, slow down, we are in trouble. When it is low, in the presence of a low TSH, the body is saying the signal is missing and the factory is empty. That is, it is a pituitary cause.